Right, hello everyone, welcome and thank you for joining in tonight. It's brilliant to see so many people logging on to the webinar. There's at least 25 of you and I'm sure more will join in as we go. Okay, so this evening we are going to focus on some basics really, the principles of IGRT, a few basic concepts regarding the rationale for it, the errors that we might expect in radiotherapy, how we might detect them, how we might minimize them, how we might correct for them, all the introductory stuff. So for many of you, certainly those that are radiographers, many of you, this will be some obvious revision, stuff you'll have covered in the past. But it's really useful to sort of go over this stuff again, and it will underpin a lot of other stuff that we do later on. So I'd also like to welcome Kath, who is going to contribute to some of the discussion later on. Now, the way that I'll just turn. I'm not away. I'm here. Okay. The way the the session will work tonight is I'm going to spend about probably 20 minutes just doing a brief presentation. And what you will see, for those of you that have looked at the page in the workbook on the learning materials, there's a couple of presentations there. This is really a sort of a combination of the key elements in both of those presentations, just to allow me and you to discuss some of the key elements within there. And what I hope this will do is allow us to then sort of generate some discussion. So it really is about sort of basics and principles. Just be aware that I expect that some of this will lead on to some discussion later on. So for the last half an hour or so, we'll see how it goes, and we'll sort of go with some discussion and see where it leads us. It's not intended to talk about any sort of really practical issues with regard to the implementation of IGRT. It's really just sort of the principles underpinning it. So just be aware that neither myself or Kath will be able to sort of talk about, in any detail, talk about some sort of the practicalities. The aim is that later on, in some subsequent webinars, and certainly later on in the module, we'll look at the application of IGRT in specific scenarios, and I'll get some people, some experts, and some people from clinical practice to talk about their own experiences, and that will be a great opportunity to discuss practicalities and sort of compare and contrast approaches. Okay, so hopefully that all makes sense. Please do type questions away in the bottom left in the chat window as we go through. I'll probably not see many of those. I'll try and keep track as we go along. Well, let's see how it goes. Okay, well, shall we crack on? Anybody got any immediate questions that they'd like to sort of get out of the way at the outset? One was around somewhere. Good question, Ken. Okay, well, hopefully you're all relaxed. You've all got a cup of tea or something better than that, and let's crack on. Okay, so where do we start? Well, probably a good place to start is to think about the importance of accuracy in radiotherapy. And we all know, we all should know, that the basic premise of radiotherapy is that we're trying to deliver a high dose to a tumour, and we're trying to miss the normal tissues. I mean, that's a basic idea. And as we've gone on over the years, we've tried to develop new technologies, new approaches in an attempt to maximize this therapeutic ratio. And we're doing this constantly. We're evolving all the time. And it's not just the technologies in the delivery of radiotherapy, it's also technologies in the way that we can assist in the delivery of radiotherapy, assist in this technology for the delivery of radiotherapy. So imaging is an implicit way of trying to achieve this. And the importance of imaging in radiotherapy cannot be understated. And whereas a few years ago, well, I say a few years ago, yeah, it really is only a few years ago, imaging wasn't drastically, I was going to say drastically important in radiotherapy. Of course, it always has been important, but less so. And sort of this appreciation of the importance of imaging wasn't recognised so much, and now it is. We're in a position now where we can't really deliver radiotherapy to the accuracy that we want in a reproducible way without using imaging to achieve this. And what's clear now is that image guidance and image guidance radiotherapy is an expected standard of care in the delivery of radiotherapy. So what do we mean by IGRT? Well, the way that we're going to move forward with this course is with the definition that's in this particular document at the bottom here. Let me see if I can highlight that. Oh, I'm crossing that out. But there, at the bottom, the National Radiotherapy Implementation Group 2012 definition. We're going to work on the basis that IGRT constitutes any imaging in the pre-treatment and treatment delivery stage that leads to an action that can improve or verify the accuracy of radiotherapy. Now, as we'll see on the next slide, there's this sort of, in fact I'll move on to that now. Most people, when we talk about IGRT, most people understand IGRT to be related to treatment verification, and particularly verification using volumetric imaging. By that we mean a way of visualizing, directly visualizing the target and organs at risk, or soft tissues, and therefore allowing us to correct for setup errors, for organ motion, and other things that are going on during the delivery of radiotherapy. So yeah, most people think about it all being related to verification of the delivery of radiotherapy, and but it's important to remember the broader definition of IGRT. So we're going to think about IGRT throughout the whole of the radiotherapy pathway as a way of using imaging to improve the accuracy and reproducibility of radiotherapy. And not just about the verification, so also about the way in which we can detect the potential errors that might occur. So we've got a number of things on this slide here. We can, so I think the reason I put this up is that over the next few weeks we're going to look at some of the modalities, some of the technology that we use in both the pre-treatment and the treatment stages of the radiotherapy pathway. So next week in the workbook we're going to focus a little bit more on the pre-treatment stages of radiotherapy and look at some of the technologies that are used to help us in imaging at that stage. And hopefully what we'll get before that is some basic appreciation of what's going on in centres around the world in terms of the technologies that are being used. Now I think I understand that we've probably got a good idea of what's going on, but in terms of the people that are participating in this course, it's useful to find out what sort of these technologies are being used. So hopefully what we will see is that there are relatively few people who rely on conventional simulation, and that obviously CT simulation is going to be our standard of care in pre-treatment, but there's also going to be increased use of 4D CT, of MRI and PET CT within the pre-treatment arena. And most importantly, this here is that we are relying on a multi-modality imaging approach for many patients. And the week after that, we're going to focus on treatment. So we will look at some of the technologies that are used to help us to detect and correct the errors during the treatment process. And again, it's all down here, and we'll look at some of these things as we go through. And on the next slide, I hope. We have, a bit of a summary of IGRT methods and IGRT in the treatment arena. So, these are the things we're going to look at. Sort of portal imaging, cone beam CT, KV and megavoltage. And the week after that, we'll start to move towards some of the methods that we're looking at in the future. That are in fact already here and have been around theoretically and in research terms for a few years now. Certainly the idea of MR guidance, and we're going to look at that in some detail in the 4th week, so the final week of the shoot and the 4th week of the module. And we'll also look at some of these other issues. So this is quite a useful slide. I think this particular slide is in one of the slideshows that you've got available to use through SlideShare. So I'll let you to look at that in more detail and to simulate that at a later date. But there's some interesting points on here, particularly for example, in relation to dose that we see in the column on the left-hand side. And again, we'll look at that from next week in terms of the implications of dose in the pre-treatment arena. So, for example, with PET-CT, a number of people forget about the dose implications in PET, and which can be quite significant, and particularly for those where, because of course, PET is used in follow-up to assess the response to treatment. Not really image guidance, radiotherapy there, but the issue there is that there's considerable dose implications. So we'll move on to that later on in the course. Okay, so a few reminders about types of error and where they occur from. So we all appreciate that radiotherapy is not a perfectly precise process, and there's all sorts of things that can go on in the planning and the treatment that will introduce some error. And there's a number of things on this slide that give you some examples of where these things occur. And as it says at the bottom, depending on the treatment site, depending on the technique, some of these things can be more significant than others. And that can help you to think about the types of error that predominate in the process, and to help you to think about how we should detect them and the protocols that we should use in our imaging processes and IGRT processes, protocols, in order to sort of minimize, detect and correct for these errors. So as a reminder, you should all be aware of these different types of errors that occur. So random errors, as it suggests, these are unpredictable. We don't know where and when these are going to occur, but we know that they are going to occur because there's all sorts of things that will contribute to those. So, for example, we know that organ position is likely to vary. We try and minimize that through protocols and immobilization, but that's what we do. We minimize it. We can't completely get rid of that in the radiotherapy process. Breathing motion is an interesting one there, because people think, well, that's a regular process and it's not really a random error. But what this leads on to is this point at the bottom here, which hopefully you can see there, is that there is, well, this is jumping ahead a little bit in terms of the concept of systematic error, but we can have random errors can have a systematic component to them. So breathing is a good example of that. So opposed to random error, we have systematic errors. So systematic errors, these are going to be there consistent, and typically we see these arising in the pre-treatment stages, and then we see them at the same extent and direction at every fraction during radiotherapy. Now, as I said there, random errors can have a systematic component. So you could see a random error which has a systematic essence to it. So we will see that in the same direction and to more or less the same extent throughout the course of treatment. And some examples there at the bottom. We also see other types of errors, so time trend errors. If you're not familiar with these are ones that relate to things like weight loss or shrinkage of tumours. And that's tumour shrinkage, often, not always an issue, but in some cases it can be. So particularly with lymphomas, we see that tumour shrinkage can be a fairly significant issue. For those of you waiting for the dog, bingo. So yeah, okay, organ defamation. Sorry. Apologies. Okay, right. Organ defamation. Yes, there are certain examples where we see the effects of organ defamation on treatment, and that can be quite significant in some cases. Corpsing during a webinar, brilliant. But this particularly important. This is in some cases. So, for example, in the delivery of treatment for prostate cancer. Hi Roz. Roz also has a miniature schnauzer, and I'm sure Roz appreciates the problems that they give us. Yes, so yeah, in some circumstances, the effects of organ defamation can have a fairly substantial impact on the accuracy and reproducibility of treatment. And yeah, it's good to see some people commenting here and the impact of all these things. And we'll look at these issues as we go through the course. Okay, I wasn't meant to put this one in any detail, but one of the things I wanted to comment on in relation to this slide is this distinction between translational errors and rotational errors, and the significance of these. And we were all familiar with, if we think back to the past where we used portal imaging to be able to detect simple translational errors, we've moved on from that in the sense that we also appreciate now that there are often substantial rotational errors that we need to try and take account for, and sometimes it's very difficult to do that. And it depends on what way we use to be able to detect and account for these errors. So, for example, there's a little bit of a mistake there. It says EG ultrasound cannot detect rotational error. It should say 2D ultrasound can't detect for rotational error. And we're now moving towards a scenarios where we can make good attempts to and correct for these both translational and rotational errors. And as an example here, using ExactTrack for head and neck patients, and being able to try and use these 6 degrees of freedom couches to be able to do that. And I think there's been a few comments already in relation to article of the week for this week, where people have recognised some of the issues associated with it. I think 1 or 2 people have commented on things like having 4 degrees of freedom couches where we can correct for roll, but we're not, in some cases, can't correct for pitch and yaw. We'll talk about that in a moment. So we'll come back to that. Okay, yeah, here we go. So if you're not familiar with these full rotational errors yet, we need to also consider roll, pitch, and yaw. So roll, it's all on here really. So we're talking about pivot rotation. So right here, so patient moving in this direction. Pitch is sort of pelvic tilt as an example. So patient moving in this direction, in the axis. And yaw is patient twist. So again, here we're talking about patients moving in this orientation. I'm sure that all of you are familiar with this, but if not, useful reminder. So at this point, it's useful to have a bit of a summary and recognise that errors exist in the radiotherapy process and they can be significant. And if we want to be able to enhance the dose that we deliver and minimise dose to normal tissues, then we have to minimise this, be able to detect these errors and correct for them. And IGRT is the way in which we do that. And IGRT occurs throughout the whole of the radiotherapy process. Importantly, I've not mentioned this yet, it can inform our understanding, our analysis of errors that already exist. And we can use this to determine the margins that we should be applying to populations and or individuals. If we're moving towards individual applications here, then we're starting to talk about adaptive radiotherapy, and that's something we'll move on to and talk about more as the course progresses. Okay, so in terms of some basics of correcting for errors, we can talk about offline approaches and online approaches. So offline, I mean, it's all fairly self-explanatory, and I'm sure you're all familiar with this. Okay, so offline errors, offline corrections of errors, we're taking an image and then we're looking at it after the treatment's been delivered and then making a decision. So it gives us just a quick snapshot of what's gone on and then allows us to implement some strategy to decide what we're going to do. And the most common way of employing this approach is to use a system whereby we image over a number of fractions during the first week, make a decision based on the likely systematic error, and then apply that as we go on through the rest of the treatment. Okay, online errors. I can see people are already engaged in conversation, which is brilliant, and I'll try and catch up afterwards, but we'll get some more discussion going at the end. Online correction. There was an interesting point, I think, I can't remember what it was, I think it was Dean Watson, who made a point in relation to his response to the survey, IGRT in your centre, in the workbook, along the lines of that for most of their patients, they used a daily online correction strategy, apart from a few different types of patients, which was really interesting because I would imagine that's not sort of common. So have a look on the discussion of the article of the week, and hopefully engage in some discussion there, and you'll see what Dean's written. Usually, we would want to use a daily online correction strategy if we have significant concerns over random errors existing. There's a few people here. Roz, we daily online correct everything. Okay, we'll come back to that. Okay, we'll come back to that. We'll have a discussion about that. Okay, and we'll talk about, hopefully we'll talk a little bit about correction protocols, but nothing significant. We'll build onto that later. Okay, there's a few people there. Okay. The point of this slide is really just to point you towards if you're not familiar with the advice that's in the guidance with regards correction strategies, and I'm going to flick on because we're running out of time in the presentation here, and just talk a little bit here about sort of a gradual move towards strategies for managing intrafraction error. And we've got some suggestions here and some solutions for how we do that. So at the simplest level, we could take an image before the treatment is delivered, we can take an image afterwards and then make some judgment about whether there's been any intrafraction error. Of course, we don't know what's going on during treatment. But true intrafraction assessment, we've got other ways of doing that. So we can use some of the things like use implanted transponders, or at the other end of the scale we can use MR guidance to be able to do that. Okay, at this point I will point you towards some reading that you're probably already very familiar with, and in order. So going backwards in time, towards safer radiotherapy, yeah, not really relevant to IGRT as such, but it does give you some useful background information about errors in radiotherapy and what we need to do in order to try and minimise those. The on-target report, and I should know the date, I think it was 2008, but forgive me if I'm wrong. The on-target report goes back a little while, but it's still got some very relevant information there about error correction and issues with regards calculating random and systematic errors. That's a really important report to read, particularly in terms of verification, but it does sort of tend towards the planar imaging rather than volumetric. And then we're moving towards here, what we're up to now, which is the NRIG reports in 2012 and the subsequent report from the leads on the supported documents and the implementation of this. So these are the ones on the right hand side that are really worth having a look at and a read through. But as background reading, both of these are essential. Okay, right. Now I've sort of lost how the conversation's gone. I've tried to rush through that really quickly, but what I wanted to do was to leave at least half an hour for us to be able to sort of discuss some issues as we go through. And I've been hearing this ping over the last sort of 10-15 minutes or so. So I'm going to turn my video off for a moment and my talk, and quickly go back, and then I shall come back on and we'll see where we're at.
Rob, can you hear me?
Yes, Kath, I can.
I just thought I'd come in whilst you were having a look over the chat.
Yeah, there's a lot to catch up on.
Yeah. One of the themes that was coming through was that people were commenting on was the move towards adaptive radiotherapy.
Okay, do we mean adaptive radiotherapy? Sorry, I've not caught up yet. Do we mean adaptive in the sense of plan of a day or true adaptive radiotherapy?
Well, that's what I was trying to sort of explain on some of my chat, but the reply, but it's difficult when there's lots of people chatting as well at the same time. So I just thought, for those that might have missed some of my comments, I just thought I'd talk through some of those as well.
Yeah, go ahead.
Like you said, I think the main sort of point to make about adaptive radiotherapy, I think, is just the main premise of it really, that it's moving, it's sort of going further than just correcting for geometric positional changes. So obviously the standard with IGRT treatment verification is to, you know, like you were saying, we'll measure an error that might be translational and also rotational error, and then we'll correct for that error, positional error. So that's sort of correcting for changes in position. But what adaptive radiotherapy takes it further and acknowledges that in addition to a positional change, the target might have changed in shape or size. So the bladder, as I think a lot of people were mentioning, is a good example of why adaptive radiotherapy is good for that particular site, because the bladder obviously can move and post supinf, superior in particular, but one of the main problems with bladder radiotherapy is actually the way it changes in volume each day, and with that the actual contour of the bladder and the size of it changes quite dramatically on a daily basis. And so that is a good example of a site that would benefit quite significantly from adaptive radiotherapy, because you're not just correcting for position, you're correcting for those changes, those daily changes in shape and size as well. So I think there's a number of ways in which people are adapting for bladder radiotherapy now, but one of the early methods was this sort of plan of the day. So departments would create several plans at the pre-treatment stage. Usually it just involved different plans with different PTV margins, and the margin would normally differ in the superior direction. So because that's where they know there's the greatest amount of movement. And so several plans would be created with different PTV margins in that superior at the superior margin. And then the radiographers on the treatment set each day would use the plan that fit best the bladder size and position that day. But what they would normally do first is do a positional correction first. So get as close to as possible where you need to be, and reduce the error as much as possible through a positional correction, and then find the plan of the day that best fits the size and position of the bladder. So I don't know whether anybody is doing that, but that's one example of adaptive radiotherapy. Another much more simple example of adaptive radiotherapy when it was first sort of starting to be used is, I know a lot of centres will often, if they're not doing daily online correction, will do this imaging of you know, images in the first week, whether that's the first 3 fractions or 5 fractions. They'll then do a correction for the systematic error, so they'll reduce that systematic error hopefully to a significant degree for that particular patient. And what they might then be able to do is, if the random error is also quite small, they might then be able to reduce the PTV margin for that particular patient from what was originally planned. So that's a much more simpler example of adaptive radiotherapy, but it's still adaptive in the sense that you've done more than just correct for positional error. You've changed the original plan. So I think that's the main point at this stage early on in the shoot, to sort of get that message across about what adaptive radiotherapy is.
Thanks, Kath. Yeah, that's exactly right.
Sorry, just to say one more thing. I mean, like you said, the ultimate form of adaptive radiotherapy, moving beyond the plan of the day, is to obviously not create lots of plans at the pre-treatment stage, trying to predict what the variation might be for that patient, but to obviously just go with one plan, but then adapt the plan on a daily basis based on the size, the shape, the position of the target, and do this daily online replan. But the technology is still, I think, not advanced enough or available enough in all centres for us to be doing that. And obviously there's lots of implications. You know, a lot of centres are still sort of battling with getting to just do the daily online positional corrections each day, never mind replanning on set as well.
No, that's, yeah, exactly.
That's the ultimate form.
Yeah, no, and as you say, there's all sorts of issues with using cone beam CT for planning and so on. There was an interesting, I think Kirsty and Roz, again, it's hard, there's so many people on here, it's hard to keep up, talking about scanning bladder volume using Rationale or 3D ultrasound bladder scanners. I've got a, was it Kirsty, do you want to, I think Kirsty said you do that. I'm not sure whether, Roz, do you do that as well in Ipswich? I have an MSc student who, okay, thanks Roz, I have an MSc student who's evaluating this at the moment, but it'd be interesting to know what other people do using ultrasound for verifying bladder volume. I mean, it's not truly image guidance. It's I mean, I think as far as I'm aware, it's being used as a way of assessing whether bladder volume is within tolerance for treatment. So, it's on the edges of image guidance there. Kirsty, I'm going to see if type in.
I have a student looking at that as well.
Ah.
So I think my understanding of the bladder scanning is obviously we know that using the ultrasound as a way of measuring error and then correcting for it isn't the best in terms of all the sort of inherent inaccuracies associated with it. And we have cone beam CT now that's obviously arguably a better modality. But I think there's this move towards using the bladder scan initially to see how close to the intended bladder volume that the patient is. So obviously, for prostate, a lot of departments will require that the patient has a full bladder. So I think the idea is that the department, the radiographers would do an initial ultrasound scan, compare that the bladder volume on the ultrasound scan to the bladder volume when it was originally planned, and then not going as far as actually registering the two images and measuring a precise error, but they can see, I suppose, in a more crude way, how comparable the two volumes are. And obviously, if a patient had a really empty bladder and they needed a full bladder, the radiographers could go and ask them to go and have a bit more water to try and fill their bladder up further. And they would have done all that before they've even had to take a cone beam CT scan. So it's a way of having a look at getting a rough idea of how how well the bladder volume relates to when it was originally planned, without actually giving a cone beam CT dose. Does that make sense?
Does to me.
Yeah.
There was a few points earlier that people have made about dose. I think, Ben, I can't remember, there's a lot to go back, and I think they've all lost now on my screen here, but there's some issues that people raised about dose there. I don't know if anyone else wanted to sort of bring that back to the fore here. Obviously, also no dose, but you know, if we're talking about, I can't remember what people talking about. I saw it earlier. People talking. I think it was cone beam CT and issues with dose there. And clearly, this is potentially an issue if we are undertaking daily online imaging. Danielle, yeah, I think so. I did scan through all the comments. I may have misinterpreted what people were talking about. Yes. Imaging may not be needed. Okay, yeah, so this is a... Okay, yeah.
I think that point about imaging not being needed is quite an important point, because obviously it depends. I think I personally you shouldn't perhaps become too reliant on imaging that it will just correct for everything. And I think if you can use ways in which you try and minimise the error to begin with, then you know you might still need to do a cone beam CT or daily online imaging, but you perhaps reducing the need to have to then correct for any errors and do repeat imaging, for example.
There's some good points coming up here.
I think that point Kirsty's just made about the KV planar images. I mean, you can actually see a significant amount of detail on those compared to what we've been always used to, the MV images.
Yeah.
I think particularly with things like perhaps implanted markers as well, they are a really useful, cost-effective tool if you're having to rationalise what you use KV for and things like that. And very quick to obviously do the registration with and things.
So it's hard to keep up. There's so many comments coming through.
I think the issue with daily imaging, and you know, like Alex has said there, it's often just a time thing, and also not having enough radiographers that have actually been trained to be competent in daily online image review. That's a really big problem as well, because obviously you want all radiographers on the treatment set to be able to at least be able to obviously image daily and correct for it if it's within protocol. There might be certain situations where you need a more senior radiographer to make a more complex decision on something, but I think one of the main problems, in addition to time, which Alex has put, is this problem of having enough radiographers trained to do the daily online imaging.
There was a comment today in relation to the article of the week. I think it was. I can't remember who it was talking about. I think it was prostate patients, about the fact that it took, in relation to the time it took to review the images, is that patients on the couch would then need to avoid their bladder, and so almost negate the whole process. Now, I did ask a few questions about the sort of the protocols and how long it took to review, but it's an important thing to consider.
I think that point Kirsty's made again, you know, in their department, the training is now intrinsic, you know, the imaging is so intrinsic to the treatment that you really do need, that is the new way, that is part of core competencies, I would argue, for radiographers now, that they are trained in image review. And arguably, you know, we need to look at it more for our students as well at pre-reg.
So Kirsty, was that... I mean, I've got this wrong again because there's been so many comments. Kirsty, did you say that you were doing daily online imaging for these patients? Okay, so was that in relation to the implementation of the technique or something else? So was it related to technique rather than patients? Okay. Okay, I think I've been missing some conversations with on here. Just looking at Ben's comment here, weighing costs versus benefits, surely knowing the patient has correct size bladder and rectum being empty should outweigh having to audit staff each year. Is this in relation to a training issue? Aren't we, main question was, aren't we daily imaging CT? Sorry, I think I've missed the conversation there. Is this an argument that we should be or we shouldn't be? Why aren't we daily imaging? Okay, well, that's a good question. Oh, for Preston. Alex saying we should.
I agree.
Sorry, what was that, Kath?
I agree, we should be. I think obviously, I think this takes us back to the principles we've just been discussing really. So if you daily online image, it means that you are not just correcting for systematic error, you're obviously correcting for random errors as well. So obviously the more imaging you do, and if you correct for error as well, the more errors you're correcting for. So the rationale for using the daily online imaging is, for example, if we're using IMRT with steeper dose gradients, we need to be more accurate. If we're using tighter PTV margins because we want to limit normal tissue toxicity, for example, the rectal toxicity, then we need to use better IGRT. So the daily online imaging thing needs to be considered in the context of how accurate do you need to be based on the technique that you're delivering. So if you are still using, for example, 3D conformal radiotherapy, non-IMRT, with less steep dose gradients around the prostate, then arguably, you know, the effects of error are perhaps possibly less. If you are using slightly larger PTV margins and you've not moved to very tight ones like 0.5 or even 0.3, then again, if your PTV margin encompasses and your associated tolerances with that, you know, are sufficiently enough to not have to do daily online imaging, then that's what you need to think about with the daily online imaging, I think. Sorry, I waffled on a bit there, but you need to think back to, you know, how accurate you need to be based on the technique you're delivering.
No, I think I agree. And just reading through some of the comments that were coming through there, I think there's some very solid arguments for daily imaging here, daily volumetric imaging for this category of patients. And I think that's there was a point in the presentation earlier about making decisions about which patients this was suitable for, you know, the imaging protocols were suitable for or not. Yeah,
and like, you know, ultimately, any technology you use and how you use it has to have a proven impact ultimately on clinical outcomes for the patient. So just to take the prostate one as an example again, you know, we really do need to keep PTV margins as small as possible to minimise that dose to the rectum, and we really do need to be using IMRT because that's been proven to be much better at treating, at creating much better plans for prostate than the conventional 3D conformal radiotherapy. So, you know, if you are using best practice in the sense that you're using IMRT, you're trying to use small PTV margins because you know that will have a good impact on clinical outcomes, then that should go hand in hand with daily online imaging for prostate. So I think it's a good point that Ben's raised. You know, really, it's a shame if it only comes down to time and in particular lack of training being the only reasons why we're not implementing daily online imaging.
Yeah. Yeah, there's more people saying as well, down to capacity.
I think, sorry, again, just to go back to that, because capacity is always an issue, it takes us back just to those things you mentioned at the start as well. So having a really good understanding of like the sources of error and the types of error associated with a given patient population helps you to prioritise what patients would arguably be best suited for daily online imaging, because the reason to do daily online imaging is if you've got a large random error. If you've got a patient group where random error isn't very large and it's mainly the systematic error that you need to correct for, then arguably the benefits of doing daily online imaging are not going to be that significant. You could, for that patient group, just do systematic error correction after the first week, for example, and then just weekly imaging thereafter, compared to another patient group where you know random error is significant. So going back to the bladder example, you know, that would be a good reason to do daily online imaging because of the random error associated with bladder filling.
Okay, I'm just going to pick up a comment from Amanda here. We used to do cone beam CT first 3 fractions, but after an audit, the medics decided to reduce to weekly. And then a few moments later, we image and shift and treat. Amanda, can you type again? Just give us a bit more information about the context there. I might have missed something. Is this for all patients, or are we talking about a particular category here? Okay, for prostate. So we've got some variation. So this was okay. So was there any daily imaging in the first week, or was this just? Am I missing something? Okay.
Just while you're reading through, I've just noticed another reason, good reason for doing the daily imaging as well. So in addition to the steep dose gradients with IMRT, the need for decreased PTV margins, the Taunton posse have also highlighted when we're starting to move towards hypofractionation and using larger doses per fraction, then obviously that's another reason for being more accurate with our treatments and arguably moving more towards daily online imaging. There was an interesting paper actually with regards to that. I think it was in radiography, and I can't remember who authored it. It was a UK paper, and they were sort of saying, interestingly, in terms of risk of error, if you don't correct for error, you know, palliative patients are just as at a significant risk because, you know, they're either just one fraction, so if you get it wrong, you can't correct for it. So imaging is crucial, and you know, even if they're a few fractions, it's only a few fractions. So again, the opportunity to correct for it if you've not imaged, or you know, you've not imaged online, the risk of error for them because of the relatively high dose in 1 or 2 fractions is the risk of error is high, and so the risk of error should dictate the imaging protocol as well. And I just think it's interesting because back when I worked clinically, we didn't, you know, we didn't even image for those patients.
Ben's asking a question there. Even though we make systematic error corrections on all treatment sites, we've never made PTV reductions or even discussed it. Is this part of adaptive radiotherapy? Not to my understanding, Ben. I think you know, sort of, we need to distinguish here between correction for error and margins. Obviously, we can reduce margins sort of for setup error, but I suppose it comes down to an analysis of setup error in departments.
I think it's a basic form of adaptive radiotherapy because you're changing the original plan for that particular patient after imaging them in the first week. I don't think many departments do it.
No, although having said that, I suppose it's a requirement for the departments to assess setup error and make judgments about the impact on PTV.
Yeah. there's a paper, I think it's by Nykamp et al. It's quite old, it's a few years old now, but that's what they did in that particular paper. The prostate patients started with a 7mm margin, I think it was, as standard. They did imaging in the first, or perhaps it was a centimetre they started with. They did imaging in the first week, corrected for systematic error, and then for those patients where I think the random error was still relatively small, they reduced the PTB margin to, I think it was 5 or 7mm after doing that initial correction. So
yeah, let's follow this up. Is this something we can bring up, or is it a process which needs to be discussed by dosimetrists and doctors? Good question. I don't think it's within our remit to make suggestions about what can be done. Yeah, I mean, it's obviously open for discussion, and I think it's, you know, sort of imaging, verification imaging is part of the QA process, and there should be some discussion, there should be some ongoing collection and analysis of quality at all levels. You know, imaging, dosimetry, a lot really, making some judgments about the accuracy and reproducibility of treatment. I'm sure it will go on in all departments. Sorry, I'm reading through here.
just going back to that daily online imaging theme that Ben and others have been discussing, I guess another possible way of sort of prioritising who is daily imaged or not would be, so say your standard protocol for prostate patients was the sort of typical days 1 to 3 then weekly, or days 1 to 5 or whatever. When you did the sort of the average error correction at the end of that first week, if for that particular patient there was a very large random error component still, despite, you know, remaining after that average error correction that you've done, so for that particular patient the standard deviation around that was large, you could then on a patient by patient basis decide whether you then move that particular patient onto daily online imaging. I don't know whether anybody does that. If for specific patients it's clear after the first week of treatment, you know, you're going to have a problem with a particular patient that's moving a lot, or the bladder or rectal volume is varying a large amount.
Yeah.
Yeah, so I'm presumably sometimes do you start with sort of trying to make a correction after say 3 fractions, but then for some you sort of chasing the error around and you need to take more images to get a better average.
I love that, chasing the error around.
Yeah, well, you know what I mean, essentially you're taking a sample, aren't you? And you know, when you're calculating an average, the bigger the sample, the better to get a more accurate average. So if the random error for that patient is large, it's better to take 5 images in the first week than 3 to get a better idea of what the average is and the random error around that.
Don't get me started talking about averages.
I know, sorry, that's the wrong thing.
Are we talking about means or
mean, the mean error. I think that approach is a good one then, because it's I suppose adhering to principles of like IGRT, isn't it? You're deciding who is most going to benefit from doing that additional imaging on a daily basis. So there is merit in that, as opposed to doing it for all patients, I guess.
Amanda's asking about symmetry. It is off topic. It's something I'm interested in though. We are going to have to finish in a few minutes, but I'm quite interested to sort of try and get a feeling for whether people do exploit their technology for transit dosimetry and employ it in their QA process. Emmett's making a good point there. Yes. Lex has left us in the lurch there. We have trying to keep up. There's so many comments coming in. Okay, people, we have run out of time, and it's been brilliant. I've barely been able to keep up with people's comments, but in terms of the extent that I've been able to keep up, it's been great seeing people's input. It's been really good seeing the conversation that's going on. I will record this. It will be available probably towards the end of this week to you via YouTube as a recording, and for everyone else. We've sort of gone off track a little bit in the sense that we've sort of diverged somewhat towards issues of protocols and other issues, but that's the way the conversation went, and there's nothing wrong with that. So thank you ever so much for your contributions. It's been brilliant, and hopefully it's given you some enthusiasm and sort of encouragement to participate in the rest of these web chats and the tweet chat on Thursday. Let me put the video back on. Don't really need the video, but if you are going to participate in the tweet chat on Thursday, I would encourage you to try and complete the little mini survey in the workbook. The survey is there not to collect data on processes. It's purely there to collect data. Thank you, Wilma. To collect some information on what's going on in your centre, so that it will inform the tweet chat and give everyone else an opportunity to appraise and compare and contrast what's going on locally to what's going on globally. So do that, it would be brilliant. Next week, Wilma is hosting. Thanks for participating, everyone. It's been brilliant, and I shall see you online, and I shall see you on in the tweet chat on Thursday. Nighty night.